So we are continuing with the second panel, and welcome. So we have Dr. Carla Melo from Brazilian Diabetes Society. Then we have Dr. Amos from Kamuzu Central Hospital in Malawi. We have Professor Basit from Pakistan, and you have Mona Osman from Lebanon. So please welcome. While they are taking their seats, can I have a straw poll? How many of you are clinicians who are seeing children with type 1 diabetes in this hall? Not more than 15. How many of you are administrators who are managing the programs? 7, 8, okay, fine, all right. Okay.
I will need this because my blood is going up. Of course.
All right, so we'll follow the same pattern. We'll give them 5 to 7 minutes to each one of them. We'll then open for discussion, and then we have a conclusion of this session before you break for your coffee. So we'll start with Carla Melo. You have some slides?
Yes.
Yeah. You're welcome.
Good morning for everyone. And on behalf of BENT, I would like to thank for the invitation to participate in this very important meeting. So let's talk about type 1 diabetes in Brazil, challenges and strategies to overcome them. I am representing the Brazilian Diabetes Society that has 55 years old, and its mission is spreading knowledge in pursuit of the quality of life and the happiness of people with diabetes. Brazilian Diabetes Society develops its action through new education and assistance standards, new digital formats, and new technologies capable of maximizing learning for large audiences, especially in distant centers. Do you know that we are a very large country? The Brazilian Diabetes Society, among its members from different departments, one of these departments is the Public Health Department. Partners and audiences encourage diversity, equity, and inclusion as practices that are essential to diabetes care. Sorry, but I forgot to introduce me. I am Carla Melo, as Kaushik has said, and I'm the founder and coordinator of the Public Health Department in the Brazilian Diabetes Society. So, T1D Index showed terrible data about type 1 diabetes in Brazil. We have near 6,000 patients with type 1 diabetes, near 234 people should be alive. 10% of these patients died without the diagnosis. It's very, very important to say. And 33 health years of life are lost per person in Brazil with type 1 diabetes. What did we know about type 1 diabetes 20 years ago? The blood glucose control was terrible in adults, but also in children and adolescents with type 1 diabetes. The mean HbA1c was above 9%. This is not the only bad news. It is associated with a high frequency and incidence of hypoglycemia, mainly the worst, nocturnal and severe hypoglycemia. How many people in the room has type 1 diabetes? So you know how terrible it is wake up with a hypoglycemia, with a nocturnal hypoglycemia. We have a high frequency of nocturnal and severe. Moreover, adolescents with type 1 diabetes in Brazil, of course, with HbA1c above 9, they have complications. I'm talking about people that has less than 20 years old. 31% of these people has microvascular complication of diabetes. The great majority one complication, but we have 1% that has 3 or more complications. So this is a terrible scenario, and you have to change it. So what we have done to change this situation? The Brazilian Diabetes Society has worked a lot with the Ministry of Health with the intention to modify this situation. So we have an evolution of therapeutic of these patients. We have constructed with the Ministry of Health the clinical protocol and therapeutic guidelines of type 1 diabetes. The Ministry of Health do it in collaboration with the Brazilian Diabetes Society, which says this protocol. The first step is diabetes education added to insulin. With diabetes education, it's impossible to have a good control, diabetes control. So the first step is diabetes education, NPH, and regular insulin. But if the patient presents severe hypoglycemia, only one report of severe hypoglycemia, or 2 or more events of nocturnal hypoglycemia per week, he can, or a bad control maintained for more than 1 year, the patient can go to the next step. The next step is the introduction of short-acting insulin analogs instead regular insulin. How did we achieve this? The Brazilian Diabetes Society conducted a systematic review with meta-analysis comparing short-acting insulins in a pool, Lispro, Aspart, and Glulisine, and we compared this group with regular insulin. And the results were what we expected. The group of short-acting insulins had better postprandial blood glucose control, less than 20 milligrams per deciliter in the three main meals. They have 45 less nocturnal hypoglycemia and 33 less severe hypoglycemias. So we discussed these results with the Ministry of Health, and the short-acting insulin was introduced for our universal health system. But after the introduction of short-acting, we have the introduction of long-acting insulins also, asked by a Secretary of Health in the Brazil. But okay, it's very nice because the results indicated also that long-acting insulins could improve the blood glucose control. And fortunately, we have something that I didn't hear about here, EPI to give support to the patient to conduct a so difficult treatment. Count carbs, correct the blood glucose, it's very difficult to do this without a support. So we have, for free, this app was created by me, my husband, and a friend that is an engineer. Its name is Glick, and it's free for patients and for health professionals. But we are discussing on continuous glucose monitoring and insulin pump. Those are the next step in our conversations with the Ministry of Health. I think that this is my last scenario. What we have to do to change the type 1 diabetes scenario in Brazil? Ameliorate access and treatment adherence. One point very important, it's impossible to have a good adherence with regular human insulin. Why? Because the patient has to apply 30 minutes before the meal. This kind of suggestion is not well accepted by the great majority of the patients. Management and dispensing of medicines and supply near the house of the patients in the primary health care, because some patients doesn't have the money to transport to the reference centers. Consultation 2 to 4 times a year with specialists, which can be done remotely, teleconsultation. And we have the material to do this. We have EPI, we have mainly in the specialized centers. No bureaucratic access for dispensing of insulins and supplies for a disease that is long life. Education in diabetes and insulin therapy for health professionals, of course, but in Brazil they have a very high turnover. So we have to educate patients and family members because they can analyze the treatment that they are receiving and discuss it. And of course, we have to follow in a therapeutic evolution, bring equity for this population. Thank you very much for your interest in the health of people with type 1 diabetes. Thank you.
Thank you very much for that excellent presentation. So next we have Dr. Amos, who is the first endocrinologist in Malawi. So he's going to tell us what's happening in Malawi. Please, Dr. Amos, welcome.
Good morning, senior colleagues, distinguished ladies and gentlemen. Today, I've been humbled that I've been given a chance to tell a story about our humble beginnings from Malawi. So I will give you a bit of a background of where we're coming from or where we are now, and also give you some challenges that Malawi is facing at a level of a clinician's perspective, not as a nation. Of course, there are some national initiatives that I'm involved in that I will highlight, but today I'm taking you into a clinical setting in Malawi. So I want you to understand that I can use this? Okay, thank you. So I come from Kamuzu Central Hospital. Kamuzu Central Hospital is a tertiary facility in Malawi, and it caters for 43% of the population of Malawi. The population of Malawi is 17 million, and I am the only pediatric endocrinologist. And 48% of this population are children. So basically they call me a jack of all trades. In terms of burden of type 1 diabetes in Malawi, the incidence is not known countrywide. We're still compiling data, but the demographic health survey for Malawi by September 2024 was extrapolating that we could be having 22,500 non-insulin-dependent patients on treatment. However, where I'm working, Kamu Central Hospital with the tertiary facility, we have over 200 children and adolescents with insulin-dependent diabetes. Mind you, we are coming from a number 5. When I graduated in 2019 from Pediatric Endocrinology Training Center for Africa, I'm trained by World Diabetes Foundation. Kudos to that. Thank you so much. And the people of Malawi say thank you. We had only 5 patients, but we have grown the numbers up to 200. You could literally see that probably somewhere, a lot were dying. Not exactly that the numbers are increasing. At least we had to meet a minimum of 2 cases, new cases of insulin-dependent diabetes every month at Kamuzu Central Hospital, and 1 diagnosed as diabetic ketoacidosis. So after graduating from PETCA in 2019, I identified a few workers with passion in management of diabetes, and also we mobilized a little bit of resource from one of the banks. We bought glucometers, glucosticks, refrigerator. I would proudly say we were the first to start managing diabetes type 1 using glucometers. We bought 300 glucometers. We provided on-job training and mentorship to 1 nurse and 1 clinician, identified a space, meaning just any space. As you can see, that's the space. And we used it as a specialized clinic dubbed as endocrine and diabetes clinic. You can see on that door. And in terms of data, what we did was we adopted the Malawi government NCD's department data charts, mastercards, where we've been filling in this data. What initiatives have we been involved in as Malawi? So as Malawi, there are initiatives at the level of a clinic. So at the level of a clinic, this is our clinic. We started advanced diploma in diabetes education. This is in the network, funded by World Diabetes Foundation, and we have got senior colleagues who are here, who are heading this program, and I am one of the mentors, and it has proven to be very fruitful. It helps us offer comprehensive diabetic education, and in my opinion, as a clinician, I think it's a game changer in type 1 diabetes management. And at the same time, of course, some new initiatives in the clinic, we are also incorporating QI projects to improve care, and these projects are headed by the ADECA trainees. As an endocrinologist in Malawi, through Partners in Health, funded by World Diabetes Foundation, we've been able, with partnership in Ministry of Health, we have been able to implement projects to strengthen the management of non-communicable diseases with type 1 diabetes, and this is one of the key areas of focus. And of course, in 2021, Partners in Health, with also funding from WDF, has helped to train non-communicable disease focal person in districts, in all districts in type 1 management. And of course, I'm also supporting the PEN Plus project. So you can literally see, this is a picture showing training, mentorship of NCD focal persons in 2021. After doing mentorship in one of the sites in Malawi, I sit with guardians and patients in one of the districts to get feedback on how they're being managed and how they're being taken care of. We have also been able to provide mentorship, train more than 500 patients in various districts, and also I've been able to participate in development of e-learning models. This is also another WDF funded project, which we also feel it's going to be one of the game changers. And of course, not forgetting Sonia Foundation. Sonia Foundation visited Malawi, and I was one of their consultants during the camp. Thank you so much, Sonia Foundation. What are the challenges? So challenges are synonymous to what everybody else has been saying. Space is one of the biggest issues. Medical supplies, lack of insulin, glucometers, glucosticks, basic laboratory tests, we are unable sometimes to do HbA1c, difficult to screen for complications such as microalbuminuria, cholesterol, and issues of patient diet are also some of the issues, just to mention a few, because most of our diets in Malawi, just like any other African country, are carbohydrate based, and most of the people come from very poor socioeconomic status with very poor food choices and food availability. We all know that we have got inequality to access and availability of insulin formulations, and of course this has been reflected in differences in survival and morbidity patterns related to disease between the poor and the rich, which I have highlighted and had a conversation with some of the colleagues in the building. The rich ones are able to purchase insulin. rapid-acting and long-acting insulins, despite their persistent stockouts in our country, and usually they have better well-controlled glucose profiles. And in this case, you can literally appreciate that a clinician is unable to execute their duties efficiently and effectively, and we feel less motivated when such commodities are not available. We've talked about carbohydrate-based diets from type 1 patients. Very difficult to restrict or reduce carbs. Some families have no on 1 meal per day, and we ask them to eat anything available. That's the teaching, because that's all they have available, as long as they inject as instructed. Clinicians also get frustrated, especially when we lose our school-going children or adolescents due to unavailable insulin, and these are usually adolescents from poor families who can't afford to purchase insulin on their own. Some of these inequalities have also been exacerbated by health system challenges, especially examples of COVID-19 pandemics, where low-resource setting governments have prioritized existing pandemics, interventions to curb the existing pandemics rather than providing resources for the ongoing conditions or chronic disease that we have. Lack of trainings on type 1 diabetes for some personnel. I know WDF is doing quite a lot in Malawi through Partners in Health, but there's still some areas. Until every stone has been turned, we will still struggle in the low, middle income countries. And in this case, it means, let me give you a testimony. I'll testify, AZ female, 23 years old, secondary school going female, who was prescribed metformin as an alternative when we suffered a country-wide shortage of insulin. And we were informed 2 weeks later that the female child passed on. Imagine our frustration, considering that before she left for school, she had a better glucose profile. Imagine a brother and a sister dying within a space of 2 weeks due to lack of insulin after they have been well in the previous visits due to lack of insulin. My first 2 patients I managed, I lost them when I just opened. These are the 2 patients I managed, their siblings, when I just opened the diabetes clinic. I lost them when we had a massive stock out of the whole country. They died within a space of 2 weeks at home. We were not informed about anything. We just heard that we have lost them. Imagine the frustration. Myths and other beliefs affect type 1 diabetes care in my setting. God was presenting, talked about children are bewitched and they need traditional healers, or religious men pray for them. Some patients have been stopped on insulin, and the consequences have really been bad. Some even died. Insufficient community awareness usually delays diagnosis and frustrates clinicians, especially when patients present late in diabetes ketoacidosis or even brought in dead at the hospital. Imagine that a clinician and the nursing team has done a very good job controlling type 1 diabetes mellitus, and patients stop insulin after visiting their grandmother in their home village. Not that it's bad to visit a grandmother, but I'm talking how our system works. Grandmothers are more powerful in terms of decision making. Resource limitations impact on quality of care for patients with type 1 diabetes in this context. We all know that African settings have got problems with data on burden of disease, such as incidence, prevalence, and the diagnosis is always made on the basis of poor information and a loosely defined set of criteria. And also access to insulin is patchy and expensive. And in many developing countries, we have talked about little physician experience or postgraduate training specific to diabetes, such as endocrinologists, and consequently, diabetes mellitus tends to be managed by non-specialists. Not that it's bad, but these are some of the problems that we're experiencing. Poor late identification of type 1 complication. We are seeing too many children, for example, in Malawi at the moment with peripheral neuropathy, which we thought is not the case. I'm not sure what you're seeing, but we're seeing many of them. The stories are endless. What strategies do clinicians use to overcome barriers to effective diabetes management in low-resource settings? What we have done so far is to intense type 1 diabetes education, 1-hour session every visit, and isolate specific cases for one-to-one interface. We give time to our nurses or diabetes educators to conduct the training. Monthly visits for all patients except newly diagnosed. We do weekly for newly diagnosed, 2 weekly, depending on assessment. Use of dialers subject to available glucometer and glucose sticks. Of course, in this case, as a low-resource setting, it is very difficult with lack of available glucose sticks or worn-out batteries of glucometers. Psychosocial counseling, mental health issue for specific cases is another issue. And we are also intending to introduce the challenge clinics, adolescents only, or any other patients with any other problems. What strategies do clinicians use to overcome barriers to effect diabetes management? Continuing, we rationalize glucose sticks use. I'm sure that's what others are doing, choosing 2 days within a week and 1 day over the weekend. Our slogan is, some insulin is better than no insulin. We use some undesirable properties of neutroprodamine hegedon and soluble insulin, because most of the times we do not have both insulins in stock. So if we have NPH, we are teaching our clinicians, nurses, on how to use NPH, looking at the properties of that insulin, looking at the peak that it has. How best can we use that one insulin? What about regular insulin? If only we have regular insulin. We also look at the properties of regular insulin. That has got a bit of a basal effect. What does it mean? Maybe if they give it morning, pre-lunch, pre-breakfast, dinner, maybe it's going to help. So we are in dire need and we're having a lot of problems. Access to share knowledge or information. We are using WhatsApp groups, of course. Our numbers are accessible to our patients, diabetes educators, so that they can let us know on any emerging issues. Medicines are pre-ordered to make sure that we are aware if there is any stock out, so that we give right information to our patients. Home or school visits to understand social dynamics among specific patients. And of course, we are trying as hard to employ a multidisciplinary approach involving mental health personnel, social workers, and also considering individualized approach. Solutions. Improved access to insulin and related essential technologies for improved management of type 1 diabetes, especially as part of universal coverage, is paramount. And in this case, of course, Malawi has got is offering free insulin, which mostly is unavailable, or one is available, not the other. These improvements, of course, will require concerted action and investments in human resource, as we already talked about it, training either on job or formal, community engagements and education for the timely diagnosis and management of type 1 diabetes, as well as adequate health care financing through robust partnerships, and also Ministry of Health commitment to achieve sustainability. Further research in the low middle-income country is needed to improve our understanding of the burden of disease, risk factors, and also implementation strategies for management of type 1 diabetes, and also increase number of diabetes educators. Community engagements, advocacy, involvement of traditional chiefs, schools, religious leaders, other stakeholders such as civil societies. It should be made clear that children and adults on with type 1 diabetes should never be stopped on insulin treatments, regardless of religious beliefs or any social affiliations. We need type 1 diabetes educators, peer educators. We have seen HIV programs going on very well, and they have got a success story. If we introduce type 1 diabetes peer educators, I think it's going to be another success story. Available online platforms for managing type 1 diabetes, which already is in the pipeline with WDF campus, diabetes campus. Lastly, political will. High time African governments prioritize health in their budgets. How does the future look like for us in Malawi or in low and middle income countries? There is need for continued education, better resources, and more widespread access to care. Encourage further collaborations and innovation to ensure that diabetes and other NCDs are effectively managed at all levels of the healthcare system. My conclusion, we have made some milestones with what has already been done, and we can do more if we foster a culture of collaboration, partnerships, to reach a wider audience, and also learning from the best practices. With continued support from multiple stakeholders, like we are today, and commitment by Ministry of Health in low middle income countries, it is possible to win war against type 1 diabetes. Thank you.
Probably when we have a next conference of type 1, Dr. Amos will be the director in Ministry of Health. So wish you the best. Thank you. So Professor Basit, please let us know the story of Pakistan. Thank you.
Thanks, Kaushik. I do not have many slides, or in fact, no slides. So I'll just go. I know the previous speakers have illustrated many of the challenges and the solutions. So I'll come from Pakistan, saying that we have 33 million people with diabetes in Pakistan. So perhaps more than population of many Scandinavian countries, 33 million people living with diabetes in Pakistan. We started with the concept that capacity building is the most important solution of the challenge, that lack of doctors or lack of trained doctors. So we have been training doctors in diabetes. We do one-year diploma in diabetes. We do fellowship programs in diabetes. And then we realized that diabetes cannot be catered by these specialist doctors in secondary and tertiary care. So we started concentrating on primary care physicians. And this is now our goal, to establish 3,000 primary care diabetes setups in the country by training doctors. We then realized that enough is not for training the doctors, we need to train diabetes educators. So we started with training diabetes educators as part of the multidisciplinary team. We've been again doing first diploma in diabetes education. We developed a National Association for Diabetes Educators of Pakistan, but now we are training for 3,000 educators to be part of those multidisciplinary clinics. In 2009, we embarked on a project with WDF that type 1 model clinics shall be established, which may be part of the main diabetes clinic or separately. So we train doctors then into specialist training for type 1 diabetes management. And we have got 34 clinics in the province of Sindh. And now with CDIC, we are having 34 clinics across the country, which are specially catered for looking after type 1 diabetes. Then the question came for data. So we started our own diabetes registry. I know people have been talking about government support or resources, etc. We are a firm believer that there's always a first step, even if it's 1,000 miles walk. So we developed our own register, took it to the registry. We started with small centers. Now larger hospitals are sharing data, and we are planning to make it a national registry. And the government is almost there to accept it as a national body for a diabetes registry. From this registry, we expect to get prevalence of type 1 diabetes, the numbers which we do not have right now. We have lately embarked on a study which is incidence study for type 1 diabetes, because the last incidence study for type 1 diabetes in Pakistan was done way back in 1994. So unless we have correct numbers, we will not be able to assess how are we going to reach them. The final thing is service delivery. So yes, we started with NGOs, we started with collaborations with WDF, with Life for a Child, we have got a support, we run a program, Insulin My Life. Now with this part, we have got the CDIC with Novo Nordisk, we are running this program. We have got NGOs which are playing part in type 1 diabetes. We know the challenges, we all heard the challenges. We are talking only of solutions. The solution is that say yes to everybody who wants to collaborate. May he be a researcher, physician, educator, nurses, NGOs, civil society. Government itself will play the role one day or the other. I have stopped committing on government goodwill, but we believe in advocacy. For the last 10 years, we have seen changes. I believe in optimism. I would say no to only those who would say no to our optimism. Thank you for your attention.
Thank you very much. That gives you the complete perspective. And now we'll hear from Mona regarding Lebanon.
Thank
Yes,
you.
please.
So we move with this one. This one, okay.
This one. Yeah. Okay.
Okay. Okay, so good morning, everyone, and thank you for the invitation. So I will be presenting the situation in Lebanon, but from a practitioner, a family physician view, and later on reaching from a system-based view. So I would like to present to you first Lebanon, to know the context of Lebanon. So Lebanon is a small country in the Middle East, and it was lately classified as a low middle income country. In Lebanon, we have a mixed health system. So we have a very strong private system with a public-private partnership. The Ministry of Public Health provides partial hospitalization coverage, both in private and in public hospitals. This is for secondary and tertiary care. And at the level of the primary health care, there are several primary healthcare centers within the network of the ministry, providing essential primary healthcare services at discounted prices, including medications, chronic medications, and including the regular insulin. So we don't have, at the level of the ministry, the new insulin, the analogs. We have more than 50% of the population do not have any health coverage, and they rely on the Ministry of Public Health. And this number increased more in the last few years with all the with the crisis that we faced. And there is a very high out-of-pocket expenditure on health. We have a high rate of unemployment and high rate of immigration in the last few years, mainly doctors, nurses, and other healthcare providers. I don't know why it looks like this. It was nicer on my laptop. But anyway, and so this is to show you a series of challenges that we faced. So it started in 2011 with the Syrian crisis, but since 2019, and over 6 years, I think the country was upside down, in fact. So, we started in 2019 with the economical crisis. 2020, we had the pandemic. Everyone had the pandemic, but on top of this, we had the big Beirut explosion, the port explosion. Later on, we have, the collapse of our currency. And also there was lifting on the support that was done by the ministry on certain basic commodities, specifically health commodities and specifically medications and supplies, which means that the price of the supplies and the medications increased. And lately, in the last year, and specifically during the summer and fall, we had the war. And all of these really put a lot of strain on our healthcare system, and specifically for patients living with chronic diseases, including type 1 diabetes. In Lebanon, we don't have really a registry until now for the non-communicable diseases and for type 1 diabetes. We don't know exactly what's the number, but the estimation based on several studies is that we might have 6,800 up to 10,000 patients living with type 1 diabetes. So if we start from the perspective of a clinician in our clinics, so the main challenges that we face in diagnosis and management for type 1 diabetes can be classified into three categories. So we have patient-related, we have society-related, and system-related. So in patient-related, of course, lack of awareness about type 1 diabetes, delayed about the symptoms, if I can say, the delayed presentation, which means we have a late diagnosis. Sometimes you have the denial also, whether of the patient or their families, that they have this disease. And of course, the lack of financial coverage. So this will lead to inability to perform whether diagnostic or the follow-up tests and consultations for ophthalmologists, etc. They cannot afford the insulin pumps and pen, and they have limited access to glucometers and strips. Of course, this is not their problem. In fact, this is the problem of the system, because the system, we don't have a national healthcare system in Lebanon, as I mentioned, so it relies mainly on the private sector, and the coverage of the outpatient services is variable. So if you have an insurance or a third-party payer, sometimes you can be covered, but for the majority of people, they don't have this coverage. They have challenges in the follow-up, namely at the private level, because they have to pay out of pocket for the consultation of the doctors. We have limited consultation time in the clinics. So you cannot spend really enough time with the patient, maybe to educate them. Challenging coverage, as I mentioned, for outpatients, specifically for physician consultation and tests. They have limited or no coverage for the insulin pumps, the pen, glucometers, and strips. Most of these are paid out of pocket. We don't have a national clinical guideline for type 1 diabetes. And also there are some challenges in the coverage at the level of the inpatient care and the emergency room services, if there is any, for example, hyperglycemia or etc. And as in fact, the type 1 diabetes care is not well integrated at the primary healthcare level. We're better a bit than Malawi. We have 8 pediatric endocrinologists, less than 10. But we don't have, and they are mainly concentrated in the big cities in a way, so we don't have access at the rural level or at the far places. And we have lack of adequate training on type 1 diabetes care at the level of the primary health care, which of course will affect the quality of care that is delivered. The unavailability of the guidelines will lead, of course, to lack of standardized care for type 1 diabetes. And we have inequitable access to quality health services, because those who can go, for example, to private clinics, like, for example, at the American University of Beirut, where you have pediatric endocrinologists, they will receive really a top-notch, if I can say, care, and they will have a multidisciplinary approach for the care, and etc. So they are privileged to a certain degree, but they have to pay it out of pocket. And also, you have, parallel to this, you have a center that is managed by a non-governmental organization that is specialized in type 1 diabetes. This is where most of the patients with type 1 diabetes, they go, but it is mainly, it is localized in Beirut, in the major city, and so it is not very accessible to those living in the periphery. And the others you have, and they will have to go to primary healthcare centers that are within the network of the Ministry of Public Health, where you have maybe adult endocrinologists, where you have general practitioners, but the general practitioners are not very well trained. And in some cases, you have some support, but very few, and you can name them, you can count them on the few centers that are supported by international NGOs or national NGOs. So also they have the limited access to glucometers, strips, medications, etc. will lead to complications, of course, which will make the care more expensive. And as I mentioned previously, the limited consultation time and the absence of multidisciplinary time will limit patient education, which of course we consider very essential. What do we do at the level of our clinics? For example, when we face these barriers, usually we refer to these NGOs, we refer to philanthropic associations who can cover these patients and support them, whether for the medication, whether for hospitalization, or if we don't have this support, we might choose alternative or non-ideal. We have to resort to that, at least that they will receive at least the least possible care. Regarding the perception of the role of patient education, of course, this is instrumental and this is integral to the care that we provide, which is person-centered care. And we conduct patient education, sessions as part of, this is mainly part of a project that we have with the World Diabetes Foundation and the CDIC. So in fact, even with the displaced people during the war, we were able to conduct some of these sessions in the shelters, in the collective shelters. And of course, the support groups, we have some support groups in Lebanon, patient support group and family support group, but they are still not very well spread at the primary healthcare level. So what we can do, what are the recommendations at the national health level to really improve the care for patients with living with type 1 diabetes? First is to integrate it better at the level of the primary health care. Second, to improve the coverage of comprehensive care for these patients, whether for outpatient level, inpatient, and also to integrate the psychosocial, and also at the level of the supplies and the medications, they should be covered. To add human resource capacity at the primary healthcare level that is needed to provide this multidisciplinary approach, whether psychologists, social workers, nutritionists, and at the same time encourage the task shifting, specifically building the capacity of nurses to become health educators in a way, or community health workers also, they can play a role there. Allocate enough time for patient education in the outpatient care, organize patient and family support groups at the level of the primary health care, which currently do not exist, and strengthen the outreach activities, because this is from where we start on raising awareness and decreasing the stigma. So working with the schools, working with the community, and educating them on what is the type 1 diabetes, that this is not an infectious disease, because still we have this myth circulating among the people that it might infect others, that this person is different from others, and etc. So this is, again, raising public awareness. And I think it is very important to build the capacity of the primary healthcare providers regarding recognition, diagnosis, and management of type 1 diabetes, and improve documentation in terms of electronic health records and registry. In fact, many of these recommendations we are trying to cover as part of the project that we have with as American University of Beirut, in collaboration with the Ministry of Public Health, with the World Diabetes Foundation as part of the CDIC of the Novo Nordisk. And we started, in fact, the capacity building of the primary healthcare providers through having a blended NCD certificate covering not only type 1, type 2, and also hypertension. And at the same time, working with the schools and with the centers centers, the primary healthcare centers, to enhance their outreach capacity and start collaborating with schools, and also building a national registry. So hopefully next time, if we'll have a meeting, we can brief you on what have been done based on that. Okay, thank you very much. I'd like to end with a beautiful picture of our country. So I started with maybe painful pictures, but this is in reality Lebanon, and I invite you all to come to Lebanon. Thank you.
All right, so questions, comments, contribution. So 1, 2, 3. Yes, start from there. Can you please raise your hand? Yes. Yeah.
Thank you. I'm Rasmus from Steno Diabetes Center Copenhagen, and this is a question for the wonderful gentleman from Malawi. Respect for all the work that you do. It must be a very meaningful job that you have, so really admire that. Wonderful presentation as well. I would like to know what you see as the main challenges in building the registries that you want to have so badly, because as you know, prevalence is a product of the mortality and the incidence, so the cases coming. What do you see is the most difficult in estimating or in building the system? Or yeah, that's what I would like to know.
Thank you. Second question was here. Yeah.
Thank you. I am Suzanne from Cameroon, and my question is for Prof. Abdul. I'm very admirative of what is done in Pakistan since many years now. My question is about social workers training on diabetes. For instance, in Cameroon, the social workers are under the direction of the government, and they are in charge of taking information on infectious diseases. Those who you are trained are the same, or you have another group apart, and are they recognized by the health system? How is it work?
Right. Third question was here somewhere. Yeah.
Thank you, all of the presenters here. I am Professor Syed Zakir Hussain from Bangladesh. So my question regarding the compliance issue of the patient particularly. In this patient, as you know, this is a chronic disease, and patient engagement is one of the important part. And regarding this, any recommendation from your side, any comments? Thank you.
Two more questions, two final questions, one here and one here, please. Yes.
Thank you. I'm Sonali from Sri Lanka, and I'm an adult endocrinologist working with Type 1 Diabetes Interest Group. My first question goes to Dr. Amos from Malawi. I know you're doing a very great job with pediatric endocrinology. Do you have any plans when these kids grow up into adolescence? What is your plan for the adult care? I know you are the only pediatric endocrinologist, and the care should be sustained. Is there any plan in your country that for the sustainability of this care? And second is a comment. It's very nice to see the positive approach by all four speakers here. Yes, as low and middle income countries, we have problems. Ups and downs are there depending on the country and the situation. We all have, but I believe that first step as well as any step moving forward is the way forward for a better future. And we in Sri Lanka, we are doing that with the support of LFAC. And it's nice to see the commitment by all these stakeholders and the clinicians to move forward. Thank you.
Thank you. Yeah, final question here, and then we'll...
Yes, I'm Yasmin Hinawi from Egypt. Thank you so much for the panelists. Actually, it's a comment rather than a question. It's really nice to provide insulin, and this should be our primary focus, but we shouldn't be now speaking about insulin alone. In other parts of the world, they are speaking about time in range, even moving toward time in range. So we should be speaking about the concept of an optimal standard care that should be delivered to people living with type 1 diabetes. When it comes to this issue, there are practical challenges. The first challenge from my point of view is the real burden, the number, the statistics, the data. We need to work more on research. Another important aspect is the phenotype of type 1 diabetes. Type 1 diabetes is completely heterogeneous and heterogenic disease with different course, with different priorities. Diabetes in Asia is different from Africa. Even in Africa, North Africa is different from the sub-Saharan region. We need to invest more to know more the nature of type 1 diabetes, the phenotype. And last but not least, empowering and capacity building is very important when it comes to management of type 1 diabetes. Very important role of peer support and educating and empowering these people as well. Another point of view is that the role of government is very important in sustainability and improving the standard of care. But when it comes to limited resource settings or developing countries, the issue is in the government. We need a proper infrastructure of the government, a proper plan that doesn't depend who is currently in the position of the government. And this is the role of advocacy, the role of these international meetings, the role of networking. And thank you so much.
Thank you. So, the comments, short comments, we have only 5 minutes. We are already overboard, so short comments. Professor Basit, you want to start? And then,
Yes.
And then our colleague from Malawi will take on. Yeah, start, Professor Basit.
Right, thank you. My question was given from Cameroon that are we using community health workers or not? The answer is that in our government system, we do have community health workers, but they're overburdened still, unfortunately, by the infectious diseases. And so we have tried in the past to incorporate them into the non-communicable disease plan or national diabetes program. But unfortunately, we couldn't find no luck. And there is reason behind this. Not that the government doesn't want, but they're already overburdened. So that's why we started to develop this network of diabetes educators. We are in the process of now starting training the nurses. And these nurses, again, will be trained only for 4 weeks. And these 4 weeks training will be enough for them to go into the periphery or the rural areas. We are also embarking on a project which is educator-led clinics. So educators will be running the clinics in semi-rural areas or rural areas, and they will be linked by telemedicine with the center. So hopefully it will work, and one day will come when we are free of or less burden of communicable diseases and maternal child health, and then we can have these 32,000 community health workers coming into the NCD program. Thank you.
Thank you very much, Dr. Amos.
Thank you, Prof, and thank you so much for the questions. So registry, yes, we need a registry so that we can inform policy with the data that we can build. It is not cheap, it's expensive. Some of the tools that we use to build a registry, such as EMR, is quite costly, can cost millions of dollars. If there are any partners that are interested to partner and build a registry, you're most welcome. Plans for kids when they grow up. One of the most important aspects is transitioning these young ones. Now, transitioning requires mental readiness. We need to come up with a whole lot of comprehensive package. I know some partners, for example, ISPAD has got a comprehensive package, but maybe we can develop something tailored to our setting so that we are able to provide, to tick all the boxes when it comes to transitioning these children. Thank you.
All right.
Thank you, Dr. Kaushi. Another challenge that I didn't comment, and it's terrible for us, is the diagnosis of type 1 diabetes in adults. We have a lot of problems. These patients is following using other anti-diabetics, no insulin, and lose the few betas that they can preserve. So it's a problem, and you have campaigns. This could be diabetes, type 1 diabetes for children, because we lost 10% of our children, and for adults is the next one. Another point is the Brazilian Diabetes Society make available for you all the documents used to incorporate short-acting insulin. It is a dossier with systematic review and meta-analysis and economic evaluation. So you can talk with Bent, Professor Kaushik, or Mark Baroni, because I will make available this document for you. And the last but not least, Mark yesterday said that I have 50 years of diagnosis of diabetes. He forgot to say for you that I almost was born with diabetes. Thank you very much for your attention.
Congratulations. Yes, congratulations. Yes, Dr. Mona,
So the last remark, I think regarding, it was mentioned insulin. Yes, we're talking about insulin because it is important at this stage because you need to control the diabetes, the blood sugar of the patients and prevent complications. But of course, I agree the importance of the research. I think we all lack data and we all lack, to see the epidemiology more of diabetes. So I agree, we need to focus in the coming few years on having more research regarding type 1 diabetes. There was a question on how to improve the compliance, I think, of the patients with type 1 diabetes. I think this is mainly with the patient education and the self-management by empowering patients on how to first, to know their disease, to know how to manage their disease and how to live with their disease will make the compliance better, taking into consideration that we are able to give them what they need from the medication and the health care that is needed. Thank you.
So with that one, we end the session. I think you have seen the health system responses to type 1 diabetes in different countries. There are 4 or 5 things which come out. One is the quality of care. And if I remember Professor Mbania, what he mentioned, Professor Mbania, Dr. Bandeka, and myself, we were 3 young endocrinologists 15 years ago, 18 years ago. And there was a paper from Professor Yudkin which said that a child in Africa does not survive more than 3 months if he has type 1 diabetes. And I think it was at that time, we were like advocates and we said we have to change the scene in Africa. We tried our best. I think now we have children who are 20, 25 years, but the problem is the quality. Question is, are we able to raise these children with type 1 diabetes with complications, which our health systems are not going to be able to manage, or are we going to a next stage whereby we start improving the quality of care? And I think question of what type of insulin, I think insulin, whether it is human or analog, I think your health system should be flexible enough to adjust and to see, because when there is no insulin and when there is an insulin, I think it's a question of which insulin you use in a sense where you want to do fine-tuning, but you can drive on that road with a Land Rover or Mercedes-Benz or BMW, but with necessary adjustment. So I think question of insulin is important. Third thing regarding the education material, I think IDF, I don't know if Phil really is around, but I think IDF, there are huge amount of material on self-care in different languages regarding mental health, different guidelines. So I don't think resources is an issue unless you want to start from scratch, because normally in many of the projects you see everybody wants to start with a new guideline. And you find that those guidelines are just repetition of what is already done. So it's a question of having a local adaptation of already existing guidelines. And finally, regarding training, I think we need to learn from the HIV world. There was this concept of interception and perception. When the HIV rolled down to the primary care, they used to send experts from the higher care to sit down with people in primary care, train them, teach them. And then they used to invite these people from primary care up to the tertiary care to observe how the care was done. And if you use the interception-perception model, I think there should not be any issue or transmitting care or actually delivering care at the primary care. And finally, I think empowerment, using the community, people with the children, people people with type 1 diabetes, families, and community around that. And I think those are the highlights which we see from the discussions we have had. With that one, I would like to end this session, and thank you very much.